Thank you everybody for being here today. It is a pleasure, and again I would like to thank Sunstar for having me as one of the experts, as you just said. Thank you, Tom, for the kind introduction. Before I start my presentation, I would like to do a dedication to two of my most and foremost mentors in my life and my professional career. One of them is Dr. Professor Robert J. Janko. He passed away not too long ago, and he was my friend and mentor. And the other person I would like to dedicate this is Dr. Bob Bayer, professor in biomaterials. Both of them drove me to understand that biology should be our real mentor, and I am definitely grateful to both of them for their teaching, friendship, and mentorship. Okay, so let's start with these images. First of all, we'll be talking about a graft material based on 3-beta-calcium phosphate. Before I go further with my presentation, I need to disclose my presentation is definitely sponsored by Sunstar, and also there were no changes made in the clinical pictures. At best, I did some cropping, but no Photoshop or any of those alterations. So, EASY-GRAFT Classic has been a grafting material introduced and FDA approved by the late 2014 in our country, has been used before in other countries, particularly in Europe, in East Asia, and successfully. So it came into us a little bit later. I found out about this product just early in 2014, and I was interested right away in the chemistry and the biology. So what it is nothing else that it's a biodegradable polymer, which will be turning into live bone as soon as it gets to be in contact with our bone. And the particles are actually microspheres. They are coated with a biolinker. The biolinker will stick the little microspheres together to make it very convenient from an easy and practical point of view. There is a reason why it's called EASY-GRAFT, and once you get to try it, if you have time to go to the booth, please do so. So these microspheres of 3-beta-calcium phosphate, they are coated with the polylactic acid, which is the former GUIDOR membrane. And then with the biolinker, this will melt, and all of a sudden all these particles will stick together to give a nice, beautiful structure to the area that we want to regenerate. The microsphere is also porous, and we will see why the porosity is very important for our biological needs. So it is very stable. Once it's mixed in the syringe, it comes out in one piece. You can cut it in trimming. And one of the most beautiful things about this product that I find in my hands is very stable, so I can do buccal bone augmentation without any tricky techniques. So the material needs the blood, the collagen will be stable on this, and actually the blood collagen will make this material stiff and hard immediately. If we go back to the literature, it is important to know that we do need to regenerate bone. As a matter of fact, there was this very famous article by Grunder, which actually reported by the previous speakers on the podium here. To achieve an ideal aesthetic results with implants, as we all know, many parameters of importance, and the correct positioning of the implants is one of the key factors, together with the establishment of the optimum volume of hard and soft tissue. And I would like to stick with the optimum volume of hard and soft tissue. And again, Grunder and his colleagues continue saying that the presence of bone is the very first determining factor for the soft tissue contour. Therefore, clinicians, which is us, clearly have to focus their interest in the volume of bone to achieve ideal aesthetic results. And now if we look at the literature from Luca Cordaro, from the Eastman in Rome, according to Luca, the alveolar ridge resorption in partial dentures patients may interfere, and then he goes all the way to say, interfere with the safe and correct insertion of oral implants. That means it's mandatory for us to rebuild the bony dimensions. At the same time, Cordaro goes, in some cases, the amount of bone available is not enough to place the implant securely. Since an adequate bone volume is needed to guarantee long-term implant stability, alveolar reconstruction is mandatory in such cases. And if we go back to the statements from Cordaro, says the safe and correct insertion. So, Again, from his articles, really nice, beautiful review, he says that if we don't do that kind of regeneration, we may end up with unfavorable results, as we all know from our daily practice. We will end up with compromised rehabilitation. So, once we've set the basics, the understanding of where we're going, let's take a look at what do we find in the clinic every day. We may end up having periapical lesions, like in this case, non-periapical lesions, or because of periodontal destruction, we may have total loss of the buccal plate. And these are situations that we're all very familiar with. And also, based on the classification that we are very familiar with, we do not always have 4 walls sockets, and that means that presents a clinical challenge to us. Besides these challenges, we have the biological challenges, such in this case, central incisor was removed, there was a huge, large periapical lesion, and you can see the amount of destruction of the PDL, and this is 4 or 5 millimeters of lesion that was destroying the tooth. At the same time, we have the destruction from periodontal situation. In this particular case, we have a large amount of hard deposit on the surface of this tooth, led to complete buccal loss of this tooth, and actually tremendous bone loss adjacent to the natural tooth. So that periodontal or that endodontic infection really made the situation much more complicated. So just to review for a second, the socket, we might have a socket with a simple endodontic lesion, but maintaining the buccal plate. We may end up with a socket with tremendous amount of inflammation all around due to perforations or endodontic fractures, such as we've seen with the before. Or also we may end up with periodontal infection that destroys totally the buccal plate. So these are all things that we run into in our daily practice in implant dentistry. Now, if we look at what's going on from a biological point of view, we have to think about inflammation, infection, and mostly the macrophagic activity and the neutrophils activity. So these are histology from a periodontal abscess, and you can see all the engulfing of the blood vessels. This is from a paper with myself, Monaco, and Prasad. And you can see a tremendous amount of biological activities. So, that being the case, what happened during acute inflammation, we have, first of all, arterial dilation, increased the blood flow at the site, increased vascular permeability, collection of protein-rich extracellular fluid that infiltrate the leukocyte neutrophils. Sorry for this, it sounds redundant, but it's very important to know what we're going to be facing later in migration to the site of phagocytic agent. At the same time, the pH of the neutrophils and monocytes, it drops to a low pH, making the area of the extraction with an acidic environment. And this acidic environment also will lead to degradation of that material. At the same time, the neutrophils will be there, invading the region, and again, dropping the pH of the area that we are going to be grafting. As a matter of fact, in a study by Siqueira, the endodontist showed that the pH of aspirated pus from endodontic abscess is about 6. So that really brings our graft material to be challenged in a very acidic situation. And it was a statement from Mish that said the pH in the region where the bone substitutes are going to be affects the rate of resorption, and as the pH decreases, the hydroxyapatite components of ligand bone and phosphates resorb. And this was done very nice and clearly by Carl Mish, where he showed that increasing the pH of the tissue, meaning increasing the acidity of the tissue, we increase the solubility of the graft material. At the same time, same Mish brought up the solubility issue, and they looked at the porosity. So we do need some material that can take the low pH, but also has to be porous enough to allow bone to grow. And that's why the company brought up this material called the EASY-GRAFT. These are the particles, SCM. This is an SCM of the particles itself. You can see nice porosity, and it's coated by the PLGA, as I said before. Once inserted in animal models, like in this histology right here, we can see that the bone cells invade this porous area, and this will turn into good bone. And this is in human histology from Ashish Kakar, that was just published. You can see there are osteoclast and osteoclast resorbing the EASY-GRAFT material, turning into live bone. So let's go to the clinic. This is a patient of mine, Ed, came to me on an emergency. He fractured the tooth at the gum line. We already see the patient has a very thin phenotype. 69 years old, non-smoker, and we had to take the tooth out with quite a bit of buccal and lingual bone loss. Gentle extraction, I don't call it a traumatic. Our residents from Buffalo will tell you why. Every time that we take a piece of the body outside the body, it is traumatic. So we call it minimally traumatic extractions and not traumatic. And so fill the defect all the way to the ridge, nice and packed. And 3 months later, this is 1 week later during the healing time, and this is 3 months later when we placed the implant. The implant was placed according to the prosthetic design, and in this particular situation with Ed, I did place a tissue level Straumann immediate, and that is the immediately after the implant insertion. Patient came back 4 years later. This is the crown that was delivered on that implant. This is the crown, here the x-ray, and you can see how stable is that alveolar ridge with the implant. So 4 years of nice stability of the ridge. This is another case that was done at the University of Buffalo by 3 residents. I'll name them: Dr. Nam, Dr. Al-Jasser, myself, and Dr. Alexander. So this is the patient Alex, 52 years old, non-smokers. Number 8, there was a non-restorable and with a large periapical lesions. So the extraction, this is the x-ray. The extraction was done nice and gently. Degranulation of the socket. And you can see that as we were digging into the granulation tissue, the socket was bigger and bigger and bigger. As a matter of fact, this is 5 millimeters of periapical lesion. So we disinfected the area with povidone iodine according to the studies of Janko, in this case, and Christensen and Slots. And then we decorticated the palatal plate to allow all the bone stem cells to come in from the palatal bone into the grafted area. We grafted the site with EASY-GRAFT Classic, let it heal for 4 months, and this is the surgery done with Dr. Al-Jasser, surgical guide, direction pin. We did some bone expansion with the osteotomes to achieve a nice, beautiful contour. And we placed a Straumann SLA active. We did an intraoral scanning with an Arterial to give the patients temporary restorations as quick as possible. At the same time, we did a little bit of frenectomy with a dial laser. At the same time, we increased even more the buccal plate with some additional EASY-GRAFT Classic and suture. And these are the x-rays. This is a patient that travels. It's very hard to get hold of him. So between the extractions and the implant placement went 12 months. And between the implant placement and the abutment, final abutment, 6 months. You can see how nice and stable was the ridge. Now, in case we have a periodontal destruction, we have to think of periosteum as our friend. So if our friend periosteum will be destroyed here, inflamed, with lots of fibroblasts going into our grafted area. So we will have an infiltration of fibroblasts into the graft. At that point, we have to stop this process by putting a resorbable membrane. It can be either collagen or it can be a GUIDOR membrane. So until the periosteum will heal, and at that point, the periosteal cells will be able to feed our bone graft, and the bone graft will take. So one more case here, that's Sally, 76 years old, non-smokers, Fosamax for 7 months, prednisone, and hydrocodone. Number 12, the patient had constant pain on this tooth, and there was a periapical fistula with apical radiolucency. Gentle extractions, you can see very nice defect right here, and periodontal destruction. After degranulation, a collagen membrane went in, EASY-GRAFT, definitely not an elegant suture from my side. However, the site healed very well, and you can see even a 1 month follow-up that the EASY-GRAFT is already incorporated into the recipient socket. A little bit more of a severe case is 86 years old lady, Doris, breast and skin cancer, non-smoker, thank God, study to number 22, reason for extraction, advanced perio. And basically there's 80% bone loss of the entire socket. Gentle extraction, also in this case, degranulation, povidone iodine for 3 minutes into the socket. And then in this case, we did an immediate implant, and we covered the implant and the periodontal bony defect and the bony defect with EASY-GRAFT. This is the implant at the site of the insertion, and 4 months later, nice beautiful healing of the soft tissue. 4 months later, we went in with a dialaser second stage, and that's the situation. 4 months later, this implant will carry a partial removal denture. One more case with advanced perio. This is Claire, hypertension, non-smoker, 23, 24, 26. They were treated for years and years by the periodontist, and then it was referred to me for the implant reasons. And we extracted all 4 lower incisors. The 4 sites were grafted with the EASY-GRAFT. Again, EASY-GRAFT has to be placed at the level of the bony crest. There is no need to put a membrane because the membrane is actually coating each particle of the EASY-GRAFT. So suture just to hold the flap in place. A partial internal denture was delivered by Dr. Posateri, the prosthodontist on the case. This is 1 week later, this is 2 weeks later, and this is 5 weeks later. 4 months later after the grafting, 2 implants were placed in position lateral incisor, and the patient just came back for the 4 years follow-up. You can see stability of the ridge very nicely and stability of the bridge as well. Last but not least, a patient of 79 years old is on Prolia, on beta blocker, and non-smoker for severe osteoporosis. The implant was placed many years ago, about 15 years ago. Bony defect, raised the flap, degranulated, and disinfected and removed the granulation tissue for the implants. And because of the characteristics of the EASY-GRAFT, I just have to stick the material over the bone without doing anything major. Because I did not do anything to the periosteum in this particular case, I just did a coronal advancement of the flap. And you can see the patient came in 6 months after, nice, beautiful, stable pink tissue. So I would like to conclude. I know I've been fast, but I just wanted to give also Milton the opportunity to present his cases. When we use EASY-GRAFT Classic in challenging situation, we have to think about infection, inflammation, lower pH, fibroblasts, macrophagic activity, all that things that we know from the biology. So EASY-GRAFT is shown to be able to face those challenges and be successful. Just one more quick note on the biology of the TCP. TCP is degraded by the osteoclastic activity, so it does not require any additional inflammation. So it's a true biological principle, just as was taught by Janko and Bayer. And with this, I thank you for your attention. Thank you.